Hello, my name is Hope Frost, and on behalf of SBK Healthcare, I'm delighted to welcome you to this recording of our Type 2 Diabetes National Networking Forum online course. If you'd like to find out more about our online live events and our face-to-face diabetes courses, please do visit our Diabetes National Networking Forum website. Please do share your feedback for this recording in the comments section and make sure that you like and subscribe so that you don't miss any new educational content that we upload. So it is now my pleasure to hand over to our wonderful online conference chair, who is Professor Rob Andrews. Rob is an Associate Professor of Diabetes and Endocrinology at the University of Exeter Medical School. So over to you, Rob.
Thanks very much, Hope. So welcome to everyone. So what we're hoping today is this to be a really informal day that we get lots of chat and lots of questions about things. The more we have participation, the better we get out the day and things. So I'm going to start by just introducing the speakers. I hope the speakers don't mind. I'm going to go by first names, and for me, I'm called Rob, so that's what I like to be called. And I'll go in the order that they're going to speak. So I think if we can start with Nicola and Naresh, if you want to introduce yourself, because I think you're on the same.
Yeah, so I'm Nicola Milne, and I'm a DIAS lead within a primary care network in Manchester, and I work with the Primary Care Diabetes Society as well.
I'm Naresh Kanumilli. I'm a GP with specialist interest in diabetes, but also a community diabetes consultant at Manchester University Foundation Trust.
Thank you very much. We look forward to hearing from you in a little while. And then if I can ask, so if you want to turn your camera off, and then if I can ask Anjali. Yeah.
Hello, my name is Anjali Zalin. I'm a consultant physician. I trained in diabetes, but I presently work mostly in obesity care at Barts Health and also at Luton and Dunstable.
Thanks very much and welcome this morning. And then finally, if I can finish with Philippa, I think that Philippa is going to be talking with a couple of other people, but they're not going to join us till a bit later, so they'll introduce themselves when they talk.
Good morning, my name's Philippa Brown and I work for Lincolnshire CCG. I'm not a clinician, but my role is working with the Diabetes Prevention Programme.
Great, thanks very much. Just give people a few more seconds just to see, but it's looking like we've got the speakers to answer all these questions for you. So lots of people wanting to know about medication and talk about Libra and talk about guidance and talk about improving lifestyle and remission. So I think we've got the speakers that we can answer all those. And it's nice to see people also putting down wanting to meet other people and things as well, because that it's always nice to meet people in these things, even though it's not face to face. Great. Okay, so we'll probably close that now. So most people have answered, but that's really helpful. And at the end, we'll ask you, what you got from the forum, and we can obviously see if we've kind of answered that and matched that. So what we're going to move over is, so the structure for the day is that we're going to try and make this, as I said, as interactive as possible. So we'll have a speaker speak, and then we'll have time to chat. And then we've got some interactive discussion to take place. We're going to kick off with what a lot of people said they wanted to hear about. That's improving management and treatment for type 2 diabetes, effective use of drugs. And that's by Nicola and Naresh. So I'll hand over to those and close down my camera once they're up and running.
So it's nice to see everybody, and we've got sort of half an hour for this presentation, so we're very much sort of taking a bit of a headline view, so we're not drilling in any massive depth into specific medications, but hopefully we'll be pointing you in the right direction for all the various resources. So we've introduced ourselves.
First of all,
yeah.
thank you guys for the slider, because I think it was really nice to see what you guys are hoping to get out of it. So as Nikki said, we've already introduced ourselves, unless you want to reintroduce yourself,
I
Nikki.
think we're fine.
Happy with that?
Yeah.
Okay, so our program today is about continuing to improve the holistic management and treatment of type 2 diabetes. I guess a lot of you on the call would appreciate that we want to look at it in a holistic manner.
So these are our disclosures.
And the objectives for today, we hope that we'll be able to provide you an overview of the different treatments available, ensuring risk management for people with diabetes, what next after metformin. I think that's a constant question for all of us, especially the new updated guidance, and exploring the latest evidence, guidance, and clinical outcomes for type 2 diabetes medication, including SGLT2s, GLP-1s, and DPP-4s. And most importantly, signposting you to useful resources that you might use within your practice.
Yeah, and I think that's really important, because we've got to remember, particularly when we're working in primary care, we are generalists. So we've got to manage all the other long-term conditions and other things as well. So it's always really important in a busy clinic that we've got easy access to resources that can help and prompt and guide us. So definitely. And although we're talking about therapies, and I know there's more talks to come this morning that will focus on these other areas, always in type 2 diabetes, you know, the building blocks has got to be about lifestyle, it's got to be about education. We talk about no medication without education,
Absolutely,
don't we,
yeah.
within our service. And certainly we're going to be looking at prevention of type 2 diabetes, remission of type 2 diabetes. So really important that all those things are considered before we sort of dive into therapies and medications.
I think one thing we need to consider is we don't, on our discussion today, we were talking about prevention, but we're looking at a lot of angles of prevention. I think prevention of progression, prevention of complications, but ultimately, I think there are a lot of you also looking at the earlier aspect, prevention of onset. Absolutely. Yeah. So
really important. And I always say as well, the other thing where we're looking holistically, if I had a fairy godmother, sometimes I actually show that picture of the fairy godmother from Cinderella, and if I was going to get my wish, it would be that we had a psychologist working within our teams, because we know so much with diabetes is around you know, the struggles with mental and emotional well-being. We have diabetes distress, just managing all the commitments of living with diabetes on a day-to-day basis. You're twice as likely to have depression if you have diabetes, and yet less than a quarter of people, this is a survey from Diabetes UK, felt that they got that emotional and psychological support. And just signposting, this is a great information that you can get from Diabetes UK around emotional health. They cover things like fear of injections, they cover depression, they cover eating disorders as well. So do refer to that, because it really is an important aspect when we're caring for somebody with diabetes. And also just signpost you to the Diabetes UK emotional wellbeing module. And I think that's everybody should be looking at doing. It's a 90-minute module. You can dip in and out of it. It's for all healthcare professionals looking after people with diabetes, but a very important thing so that we're having effective conversations using the right language. So really important that we consider that in diabetes care.
Absolutely, Nikki. And I was talking about the depression side of things for a person with diabetes. I can remember in our clinics, we used to give out people with in the waiting room a PHQ-9 questionnaire. Yeah. So I think there's a simple thing that could be done while people are waiting in the waiting room. We're not seeing many people face to face, but you can send it online and get them to fill that in. And so it gives you a little bit of an indication about what they're going through and whether you need to be tackling something else before you get to the actual clinical management. Yeah,
most definitely. And I think with COVID, a lot of people have been very isolated, very lonely. So so this is more of a need than we've ever had before, and really important to sort of involve our whole multidisciplinary team, social prescribers, care navigators, really important.
So one thing we've always been focusing on is about, HbA1c and things like that. But equally, we need to understand about the diabetes, uncontrolled diabetes can cause life-threatening complications. And we already know this. It's like preaching to the converted
Yes.
here. About 50% of people die from cardiovascular disease. I think the importance of that will come through when we talk about guidelines, I think. And about 40% of the people with type 2 diabetes have some form of chronic kidney disease. And the other highlight, I think, for me was 60% of all non-traumatic lower limb amputations can occur in people with diabetes.
Yeah, I mean, and again, Diabetes UK did a survey looking at, our amputation rates, and they've actually, in the last data had gone up, but we were doing one amputation every hour of every day, and yet we know so many can be prevented if we get the right therapies and get this holistic care right.
I mean, all this information actually highlights more important issue about how we give information to people living with diabetes about what the importance of diabetes and what it can do.
Absolutely.
If you don't control it effectively. Like 16% of people over 65 years with diabetes die of stroke. And then not a lot of it retinopathy. I think a lot of people with diabetes know if I can go blind with this, but again, it's important to highlight
and
that.
again, in the report, diabetes is serious. I think it was less than 4% of people, of the general population, knew that diabetes could cause cardiovascular problems, and yet 50% of people, it's that massive risk.
So again, reiterating the fact, it's not just about managing blood glucose, and there should be a good focus on blood pressure, lipids, and we'll come to the evidence in a minute, and screening for and managing complications, including renal problems, retinopathy, and foot ulcers. I think that, again, with the data, the trials that we're going to talk about in a little bit, will actually tell us, these are important aspects to be looking at.
Yeah, and I just want to take us back now to 2014. So we're going back 8 years here. And just to remind people, we had just had the Winter Olympics in Sochi then, and we were doing the Scottish referendum vote, and we were worried here about the Ebola virus.
Absolutely.
So kind of forgotten about, that. I'm not sure whether we should have been more worried about the Gangnam Style there. That was the big craze of the year. But the reason I'm illustrating this is that, we've got the STENO2 study, which is a very small study, which was looking at managing blood pressure, HbA1c and lipids, not just focusing on HbA1c. And when they looked at the 21-year follow-up of this study, it showed that if we get things right, not just in terms of HbA1c, that we can live for 8 years longer. And I find that really fascinating. That could go to one GP practice that's not very interested in diabetes, go to another one that's very proactive, and I'll get 8 years. And I think about what I've done in the last 8 years, and we would want to have that, and we would have a better quality of our life as well, wouldn't we?
It's about how and one of the questions that you might want to ask yourselves who are listening is about how do we, if you're doing a good job, how do you motivate your colleagues to do the similar job, similarly effective job? Because we want to reduce variation across practices. Yeah. And if one practice, like you say, is doing more effective work, how do we support and enable other practices to do the same thing?
Yeah, I think it's always just massively important, in the community team where we're working, we always remember that high HbA1c, diabetes, it has two best friends. It's raised, dyslipidemia, hypertension, really important to treat those as well.
And what's the relationship, Nikki, between cholesterol, blood pressure, HbA1c, CVD events?
Yeah, so, we're going to, if we get blood pressure right, it's probably the first thing we should be doing, then lipids, then A1C.
Absolutely.
If we want to prevent that cardiovascular disease.
And we continue to focus on the one bit that is really difficult to get right. So more patients are needed to prevent one CVD event with regards to HbA1c. And that's probably one of the toughest things that we do.
Yeah. And I think if we go back to that STENO2 study, so, we're looking at 21-year follow-up data, and they showed that we got that 8 years extra of life. I've deliberately made this, it's a busy slide, and certainly the image on the right is very difficult to view. But that was just to show how many cardiovascular and renal outcome trials we've now had. So when they did STENO2, they were just looking at blood pressure, cholesterol, HbA1c. But now we've got all this trial data for the we know that some of the GLP-1s and the SGLT2s have got additional benefit. So if we add that into that basis of STENO2, then imagine the outcomes that we can have now.
I think this brings us nicely back to the whole thing about looking at the person as in a holistic manner,
Yeah.
looking at the other organs involved in the whole condition. So like we talked about glycemia, but we know type 2 diabetes is increasing in the UK as everywhere else. And people with type 2 diabetes have 5 times increase of heart failure in type 2 diabetes. And remember, this can occur without having a previous event. We did the audit in our practice and we had 25% of our type 2 diabetes population who had symptoms and signs of heart failure. And equally, 40% of type 2 diabetes patients develop CKD. And I know there are other causes for CKD, but I think 40% is a high enough number. And we also realize that there's an interconnection between the heart and the kidneys and how actually one can make the other situation worse. So persons with CKD have an increased risk of developing hospitalization for heart failure, MI, and stroke compared to those without CKD. And then heart failure is one of the primary causes for hospitalization in people over 65. And 1 out of 2 patients will die within 5 years of diagnosis. So heart failure can kill. So make sure that you diagnose early and treat early. So this is one of the things that we need to remember with people with type 2 diabetes. Just because they've not had an event does not put them at a lower risk of developing heart failure.
So for detecting it early, what are the sort of things that we can be doing when we're doing our review checks?
I mean, you can ask some simple questions. Maybe you should even have it on your template. Are you more breathless than normal? Are you finding it a bit of a struggle doing the usual things? Do you find your legs are swollen? So those are not, I mean, you can use them as pointers to thinking, well, should I be investigating this person a little bit more? Those are the things. Am I more tired than usual? So simple questions you can put in a template, just tick the boxes. And if it ticks at least 1 or 2 of those boxes, I think you have a duty to investigate just to make sure.
And also one of the issues we have where we're looking for chronic kidney disease or diabetic kidney disease is we don't do enough microalbumins, do we? And that's the first signal, that very first warning sign. And that's going to indicate us to get us onto certain therapies for people. And yet that's the least care process we manage to achieve, isn't it? And it's so important. And
I think you always say to all the people you teach, I'm pretty sure, Nikki, just get a urine sample. Doesn't matter whether it's morning, afternoon, evening, just get one, and then you can make a decision of getting an early morning one. And the importance is this.
And this is old data now. This is from about 4 years ago. So, you know, it's really impactful.
So think heart failure, think chronic kidney disease in a person who's asymptomatic as well, right? Especially if they have type 2 diabetes. Think about those 2 conditions. Because here again, we talk about friends and family tests, don't we?
Yeah.
Okay, I know there's evidence. Should I be looking for it? Yes, it might add a little bit more to your workload. I suspect it will. There's no little bit more, it will. But actually, you'll make a difference to this person.
And with the new guidelines, it's asking us to make these assessments.
Absolutely.
Now we'll talk about those. And certainly guidelines wise, I think we've all become quite familiar whilst we've been waiting for the new NICE guidance. We've looked to the EASD, the European Association for Diabetes, and the American Diabetes Association. And these have been quite simple, you know, in terms of following, because it's been, you know, talking about lifestyle, putting the patient at the centre of the decision making, metformin first line. And then it's been encouraging us to look, has that person got cardiovascular disease? Have they got heart failure, chronic kidney disease? Those are the columns over there on the left. Moving over to the right, do we need to look at minimising hyperglycemia, look at weight loss? And of course, the global guidelines. So they're saying, do we need to consider costs? So that's been directing us in our flow of travel. And I think the new NICE guidelines, which were just published in February, very much have looked at these cardiovascular outcome trials that we've spoken about, where we've got this favourable evidence for some of the GLP-1s and SGLT2s. And we'll just drill a little bit, because it's quite busy compared to the one we've just looked at, isn't it? So let's just simplify it a little bit. Yeah.
So if you want to go through this, Nikki,
so again, it's still advocating, you know, metformin when we are going to start looking at initiating a therapy.
No arguments with that.
And if people can't tolerate it, then it's looking at that slow release, that modified metformin. And then it's saying that if the person isn't at high risk of cardiovascular disease, then we consider DPP-4 inhibitors, our gliptins, pioglitazone, sulfonylureas, or an SGLT2 inhibitor.
I think each of us will have our own experiences about using these therapies, and I think we should not discount them. but I think we need to be considering a little bit more detail about what comes next.
Yeah, because one of the things is if people are at high risk of cardiovascular disease, and NICE are defining that of a Q risk 2 of over 10%. And we know we have Q risk 3 now, but Q risk 2 is there because that aligns in with the lipids guidelines. So if anybody at Q risk at 10% or higher, then definitively now they're saying, we cut off the back of our trial evidence, is metformin. And then as soon as tolerable, as soon as somebody's tolerating metformin, then look at then adding the SGLT2 inhibitor with proven cardiovascular benefit.
I think one question always comes back to a lot of people is, how soon do you add the SGLT2?
Yes. Yeah.
Some people say, well, I start them both. But then in my view is get them on the metformin, get them well tolerated, then add the SGLT2.
Yeah.
Because some people argue, that especially in the next group that we're going to look at, whether to start metformin and SGLT2 at the same time. But
and it's difficult, isn't it? Because if you're starting two and very often if you've got somebody newly diagnosed with diabetes and you've just done that Q risk and it's over 10%, you'll be starting a statin. They may be hypertensive, so you might be starting an ACE or an ARB.
Absolutely.
And often one of the difficulties is people with type 2 diabetes don't necessarily have symptoms. So you could be sat with somebody who's completely asymptomatic, feeling fine, and saying, here's 4 or 5 medications. And, so that's where the education is vital, isn't it?
Absolutely.
Because they're thinking, why have I got all this medication? So that education about the risks of diabetes, that has to be in there so people understand why you're giving them so much medication.
So think polypharmacy, pill burden, diabetes distress, all these things. So referring back to what we talked about initially.
Yeah. And then here they're saying that actually if somebody does have heart failure or established atherosclerotic cardiovascular disease, and at the bottom there it's defining what they mean by established CVD, then we should be using the metformin SGLT2 inhibitor with proven cardiovascular benefit. And actually for both the high risk and the established, if they can't tolerate metformin, then offer an SGLT2 as monotherapy.
So one thing that concerns me with this is, bearing in mind we talked about CKD.
Yeah.
Why isn't that on here as a person with high risk, right? So CKD we did show can cause more people to have heart disease and things like that. So maybe if they had CKD, I would treat them in the same manner, right? I know it's not mentioned.
And I think if you go to the CKD guidelines, which we're going to move on to, it will direct you there. But we have to keep going to lots of different guidelines, don't we? Just to look.
And one thing to remember when you talk about atherosclerotic cardiovascular disease, don't forget, it says it in the bottom about cerebrovascular disease and also peripheral arterial disease. Most of us, when we think about atherosclerotic cardiovascular disease, tend to think about the heart and
angina.
Okay. And so again, so this is about how to choose further medication and things like that. When the NICE guidance came out, Nikki, it was like almost going to the new Bond movie, wasn't it? Like No Time to Die, was it? Everybody expectantly waiting, and then there was a dud ending in a way. But people would argue. The reason I say that is because of this. Because in my view, I think they missed a trick here, because one of the things they say is, if triple therapy with metformin and 2 other oral drugs is not effective, consider a GLP-1 receptor analog. But they put in lots of caveats about BMI, etc., etc. I mean, in practice, when you see somebody with a problem that they're not being controlled with an SGLT2, which you're using it probably for other reasons, you still need something for glycemic control. I can't expect to be looking at BMI and then thinking, I'll wait till they get larger before I give them the thing. So that's my one drawback, I think. And I think hopefully they'll probably reflect on this and things might change. But for general, in practice, I'm pretty sure a lot of us who are managing type 2 diabetes do always look at GLP-1s as one of the mainstays of treatment, aren't they?
It's about that individualizing care, isn't it? And those discussions. And as you say, if we, here ADA and ESD do have those GLP-1s a little bit earlier on the algorithm, particularly for the established cardiovascular disease. So this is where it's important to work within teams and look at making those decisions.
Yeah, I think it brings in focus about how you organize your services and whether there's an accessibility to a multidisciplinary team meeting where you can bring patients like this and have a discussion about it. I know a lot of formularies across the country will say, oh, let's just follow NICE and things like that. But again, I go back to friends and family tests, and what would you do in this situation? And I want the best protection.
And it's important to remember guidelines are guidelines. So,
Yeah.
you know, there's always going to be caveats, as you say. So, yeah.
And just quickly looking at CKD, we know that most patients with moderate to severe CKD are managed in primary care. Whether we recognize the importance of what we're doing, I think we don't do that often about the work that we do in primary care. So patients with stage 3 CKD, 84% are managed in primary care. Stage 4, 57%. Obviously, as they get to the other stage, rightly, they should be managed in secondary care or under a specialist. But I think, remember, a huge burden of the CKD management is in primary care. And now we have tools, don't we?
Yeah, and we know that the earlier that we can manage that CKD, so get the microalbumin done, get that EGFR done, let's look at using the ACE or ARB, let's look at getting the SGLT2 inhibitors in. And again, you know, we said NICE has got the CKD, so if you look at the type 2 management, it refers you back to the chronic kidney disease guidelines. And very definitively there at the if you're going along the line, if somebody's microalbumin is above 3, you know, it is making sure that ACE and ARB is in. They will Q risk high, so they're going to need a statin as well. And again, it's talking about adding in an SGLT2 with proven renal benefit according to license.
And we know lots of the trials have shown that. So, but remember, I think one thing we need to advise everybody or reiterate is a lot of this evidence is based on top of standard of care.
Yes.
So ACE and ARB are your first go-tos.
Yeah.
All right. So make sure you do that to get them to the maximum tolerated dose. It may well be 2.5 milligrams, but they need to be on it. But the evidence has always been for maximum doses of these things.
And that's the same with the heart failure, isn't it? It's on top of standard care. So, so that's really important to remember. But again, another really busy slide. We say don't use busy slides in a presentation, but just wanted to make everybody aware, you know, we've got the type 2 guidance, the kidney guidance. We've got technology appraisals now for dapagliflozin and canagliflozin in kidney disease. We've got EMPA and dapagliflozin for heart failure. So useful to familiarise, but maybe, you know, make your top line notes so that that's handy in your drawer as you're working. And I think this next resource is really helpful. This is in the Journal of Diabetes and Primary Care, and this kind of summarises. This is looking at what the indications are for the various SGLT2 inhibitors.
It's a good way to just stick it on your on your wall, or have it on the background so you can refer to it. It just gives you a very good indications list about what.
Because I think as well the licenses have been changing very quickly. I mean, this particular article, it's live, you know, and it's had to be updated 3 times already since it was published at the end of last year.
And Pam Brown does a fantastic job of that.
And then also there's another page of it which just goes through each medication. And I think really important to remember that where we are using the SGLT2 inhibitors with an EGFR under 45, I think you mentioned before, you will need something else for the glycemic control, because it will help with that kidney function, but not necessarily with the glycemia.
And remember, it's not, again, a safety issue, it's more about efficacy. So please don't worry if the thing goes down and you think, well, what have I done? But no, it's more about efficacy rather than safety. That's why you need the GLP-1s, additional therapies rather.
So extra resources, like you say, we'd love to have talked for longer, because I think one of the things is sometimes people are anxious about using therapies. You know, they might not be as familiar with the GLP-1s, SGLT2s, you hear things like DKA and things like that, which can be very scary. But some good resources on GP Notebook. This is What After Metformin. Again, the Journal of Diabetes and Primary Care. This is how to use SGLT2 inhibitors safely and effectively. It's got a traffic light there, and this is one for GLP-1s as well. So so do use these resources if you're unsure. Speak to your specialist teams as well if you're not sure with therapists, you know.
So just go on Diabetes on the net and you'll find these incredible resources.
Lots of modules and learning as well. But just going back to the NICE guidelines
Absolutely.
as well, just some little caveats there, you know, when we are following NICE, really important flag is consider your women of childbearing potential, because we are, you know, the newer therapies, we can only use metformin and insulin still in pregnancy and preconception. So, you know, do make sure that we're not initiating these therapies where somebody may want to conceive. They're thought to be teratogenic, some of the newer therapies. And also consider your frail and elderly and what sort of appropriate targets we're working to. And I think really important at the bottom, review anything that hasn't been working. So don't just keep adding on. Make sure that if you are using therapies, you're bringing people back in a timely manner. And if something hasn't worked, stop it and start something else.
Absolutely. I think diet and lifestyle, again, for me, I think we need to reiterate everything. And I think we'll talk about the document that we brought up. But I think diet and lifestyle at every stage, you need to reinforce that. If you make that the mainstay of treatment for people with type 2 diabetes, along obviously with therapy, you won't go wrong. And I do particularly like the thing you said about, you know, women of childbearing age. We forget, we need to be asking them the question, make sure they're on effective contraception if they want to go on it. And remember to refer them to preconception clinic if they do get pregnant.
So is there a place now for sulfonylureas? And we were talking at the top there about rescue therapy.
Absolutely. I think just because we've got all these new therapies does not mean there's no place for sulfonylureas. We talk about rescue therapy. So if someone presents to you with quite symptomatic, the first go-to would be a sulfonylurea, obviously making sure they're type 1 or type 2 diabetes.
Or insulin if necessary.
As one of my colleagues said, well, you won't go wrong if you're going to help them with the symptoms, because do some symptomatic treatment, they'll feel better, then you can investigate people with that.
And sulfonylurea is still very good for steroid-induced diabetes as well. So, and you know, where we are talking about rescue therapy and insulin, just a little highlight for the 6 steps to insulin safety, which is again on Diabetes on the Net. It's free to do the module and definitely recommended. And even though you might not be initiating insulin, you'll be signing repeat prescriptions. You'll be, you know, so there's always that to it. And still one of the commonest drug errors is around insulin, which is a serious consideration.
And dare I say, this might be useful for people within secondary care as well, because, you know, a lot of the teams in secondary care probably not know much about insulin because they do lots of other things. But maybe if they're managing people on the ward, because in the current pandemic, everybody's doing everybody else's job. So nice to just get a little bit of advice and things on that.
And sometimes I think, you know, we're looking now, we're just sort of summarising, we've kind of gone through the pandemic, we've done all the vaccines and everything else, and now we're looking at how we're resetting services. And it looks like we, you know, this is how we might be feeling. We've got to one mountain top and we've got a bigger one to climb, haven't we? But just a little nod to how we can best align these services. And I think we've got Lorraine on the in the audience today, who's one of our co-authors, Lorraine Avery. But this is a document looking at best practice of delivery of diabetes care, because it's about, you know, we've got to get these right therapies in, we've got to have people confident using them early on. So it's about education and how we're supporting practices within the primary care networks.
And this is again available online, and I think it gives you a direction possibly about where services might go to, because I think we need to try and move services more into the community. And then again, it does stress, I think one of the important things that all of us authors here felt was, especially Lorraine, I think, who said we need to be doing almost like a 2-week wait for education, because if you get that right initially, they're more likely to be shared decision making will be enhanced at that stage.
It is important.
And then Nikki, you yourself now are
DIAS lead, so when I introduce myself, people probably thinking, what is a DIAS lead?
Go on then, give us a flavour.
So I sit here at tier 2, so we're saying that sort of within practice, this should be a basic level of competence of doing diabetes reviews, but then you would have a more specialist team, so that's the diabetes support team to support education and overview of slightly more complex people, so those with the heart failure, those with the chronic kidney disease, to get those therapies in, the preconception ladies. diabetes. And then this support from the community teams, and then secondary care really is for those people that need it, those super six, you know, the foot care, pregnant women, children, pumps, type 1. So certainly have a look. There's lots of good ideas and sharing of what's worked well in other areas. So have a little look at that if you're looking at organising services.
I do suspect a lot of areas have something very similar to that. Probably they don't call them that. But if you are starting off on your PCN journey, which many of us have been doing, but also I think is going to more and more come to the fore now, it's worthwhile looking at this document and thinking, well, actually, how can I support the other 5 practices or 6 practices? And see,
there was one this week, 15 in London. So,
exactly. So
in the PCN,
how do we do that better? How do we? And there's always thing about resources. I think it's trying to be a little bit more clever about how your resources that you have and getting the services down to where the people with diabetes are, rather than getting them to travel elsewhere. And I quite like the idea of MDT as well.
So just our last slide.
I was going to say, we're just running out of time.
Done now.
Yeah, so this is our last slide that just shows that actually if we all work together, you know, and let's look at all our colleagues, let's look at the whole multidisciplinary team, and together with the people that are living with diabetes as well, really important to think about peer support, we will get to the top of that mountain. Thank you.
Thank you. We'll stop there.
Thanks very much. Very kind. And it justified, very nice of you to say about pregnancy. If I can just kind of prompt people that the key thing is folic acid, 5 milligrams. Yeah. Thinking about becoming pregnant, because that has the most effect out of kind of anything we do and things. So loads of people are in the chat and things. So are you happy for us to just go straight to a couple of questions and things?
Absolutely.
So the thing that's come up a bit is safety of SGLT2s and whether we should be monitoring ketones and things. Do you have any kind of comment on that and how to safely do it? And are there people we should be avoiding giving SGLT2s?
Yeah. So I think certainly if you know that resource that we signposted people to, where we've got the traffic light system, that is really important, because we don't want to be using it in type 1 diabetes. There's risks if people are on ketogenic diets, if particularly have a very low BMI. So there are people that you wouldn't want to be using the SGLT2s, and it's useful just to look at that risk benefit tool. But I think the important thing is education. It is telling people, and I think one of the unfortunate things is, you know, we do talk about that sick day guidance. That's really important. So we talk about the SAD man and the medications you should stop when you're unwell with diabetes, but people don't retain it. We know that in a consultation there's a fraction of what people do retain if they have been given that information. So certainly we're working on a patient information leaflet, a generic one at the moment, but it really is all about that education and what the signs and symptoms might be for DKA, and also educating our colleagues, because very often with an SGLT2 inhibitor, if there is a DKA, it's often euglycemic, so the blood glucose level might be fine. They might say, oh, my blood sugars are 14 or something, so you're thinking type 2, we don't need to worry about DKA. But really important to educate all our colleagues
as to
about
giving
the risk.
This question about ketone testing, my view is no. I think it's important that every practice should have a ketone meter, functioning ketone meter within the practice. So if somebody does fall ill and they turn up at the practice, you should be testing that. But as a general rule, we've not been issuing ketone meters for people when we're initiating SGLT2s.
Okay.
What about your views, Rob?
No, I would agree with that. I mean, again, it's that cost benefit analysis, is that although it's in the literature, it's not as common as that you would give it to everybody to monitor.
Yeah. And I think somebody's just put in the chat box about the DKA leaflet that Trend do as well.
Yeah.
So there's lots of resources that you can use. And we haven't used, somebody's just saying about the ketone urine strips, so no. And there's such a delay with those as well. So it's just making sure the person knows to stop the medication if they're unwell, you know, and what might be the signs, and signposting to who they need to go to for advice.
Just remember, I think it's overemphasized, and we need to just be a bit careful about what we do.
Yeah, and in terms of when we're thinking about children, someone's asked about children.
Yeah,
SGLT2 in children.
No, I think in primary care, I would leave that to the secondary care colleagues to do that if they're in type 2 diabetes, obviously not in type 1. I think depending on the condition, we have done some work with adolescents, I wouldn't say children, but in fact, but more in a secondary care setting. I think it's more about, I think again, it's about education, understanding the condition, whether they can at least complain if they're feeling unwell. All those things need to be thought about before we just initiate. So I wouldn't advise in children in primary care.
Okay. And in terms of some surprise that we kind of were putting people at high cardiovascular risk, we were saying go for the SGLTs, and there was no mention of GLP-1, whereas of course the ADA say they are. Can you explain why NICE has got that different?
I think, so my view was they didn't seem to have, when they did the reiteration or again of the NICE guidance, they didn't seem to have all the evidence around the cost benefits. Actually, they didn't seem to have the cost analysis available to them, so they say, when they did that, despite ADA, ESD talking about that. But I think one of the things that we in Greater Manchester have done is we actually looked at all the evidence that's available, and we developed our own pathway around where GLP-1s fit. We developed our cardiorenal metabolic pathway. And so we do tend to use GLP-1s earlier on in the disease cycle, and particularly if this needed after ASCVD and things like that. So if they're not tolerating SGLT2s, you're going to have to give them a GLP-1 to try and control their risk factors and improve outcomes for them.
Something we haven't mentioned during the talk, and I'm going to bring you in on this, Rob, is the precision medicine. So where we're looking at what should we be using after metformin, because I know a lot of work's been done in Exeter on that. You know, it'd be great. I think moving forwards, we'll find that there's, you know, these different subcategories of type 2. I think once I've retired and come back, there'll be a type 2.1 and a type 2.3, and we'll be able to pinpoint actually which therapy would be. So what are your thoughts on that, Rob?
I definitely think it's the word going forward. So there are ways you can predict who responds. So if for GLP-1s, you can measure C-peptide and know whether someone's going to respond or not. So that can save a lot of money, because a C-peptide is now £6. You know, and leaving someone on a GLP-1 for a long time, for 3 months to see it have an effect, would easily be more than that. And then there are trials like the Trimaster that have kind of said that if your weight's higher or your renal function is slightly lower, then you might consider different medications. If you go to Diabetes Gene, there is a little app where you can put in people's paramounts, and it will give you the chances of the HbA1c falling and the chances of them having side effects. And then you can have a discussion with your patient, and eventually that will be an app like the Modi app that will be on the phone. Yeah. So I think that is the way that it will go.
I think, yeah, absolutely. I think we're tending to look at medications in a more precise manner, trying to, I mean, this is where individualization is going to become minted. So you're becoming almost, I don't know, send them a blood test, get it done, and then they present to you and you think, okay, I got the results. This is the best drug for you, and we'll go on it. So I think that's where it's going to go.
And I think the other thing which is really interesting is when one of the questions I think we all have is, if you start a medication and then a year later they're not doing well, do you stop the medication?
Yeah. Well,
we've been able to do an analysis of that from all the GP data, and the answer is no. If you stop it, it gets worse. You just add in. So that's at least nice that we're now getting such good data from the GP databases that we can do those analyses.
I think we are lucky in this country, the amount of data we have compared to most of the countries. So yeah, brilliant work there.
Great, that's great. I mean, I think it's worth just finishing off with that thing that you said, Nicola, is that please remember that this is guidance, and that actually you prescribing other professionals. And if I remember Edwin Gale said to me, if you use guidance as the law, like the law, you end up looking like an arse. So, you know, use your individual clinical things discussing with the patient as to what's the best way to going. And if it does detract you from the NICE guidelines, that's fine. If you had a discussion, that's the best thing for the patient, and that's the way you go.
Absolutely. I think, like you say, friends and family. So think about what you would do and individualize care, and you won't go wrong.
And, you know, if you bring people back and evaluate whether it's worked, you know, so that's the important thing as well, isn't it? So
absolutely.
Yeah.
Great. So that's a lot of a great start. Thank you very much for that. So, and I'm sure a lot of that will come up in the discussion. So we're going to hand over to our next speaker, who is going to tell us about supporting people with type 2 diabetes in your service to achieve remission. So this is Anjali. Oh, the slide's already up. Gosh, she's very organized. So she's ready
Sarah's
to go.
kindly doing that for me.
So I'll turn off my and let you go.
Thank you very much. Yes, so my name's Anjali Zalin, and I work across 2 trusts at Barts and at Bedfordshire. My primary role is actually in obesity care, and I regularly see people who are eligible for and achieve diabetes remission, and that it's really very exciting to see. Could I have the next slide, please? So this is a brief outline of what we'll be covering. We'll touch on the background as to how we got here, some concepts around remission and how we define this. I'll then cover just a wee bit on physiology, but I'll mainly aim to talk on the practical aspects of diabetes remission, the strategies and how we use these in the real world setting, and really some of the things that I've experienced, and hopefully that will be useful. Next slide, please. So just a little bit on the background. Next slide, please. So I won't belabor the point. We've just had an excellent presentation, but we can't really start a presentation like this without a discussion on diabetes prevalence and therefore the importance of remission. So we have huge numbers across the country, across the world. We have a significant financial impact. And that really is the tip of the iceberg in terms of undiagnosed and projected rises of cases of diabetes mellitus. Next slide, please. And in parallel, we have a very similar story in obesity. You'd be unsurprised to hear. We have the rising prevalence. And in fact, the majority of adults in England are now overweight or obese. So when we consider remission, we consider managing diabetes and obesity together. Next slide, please. So as I'm sure you're aware, obesity and type 2 diabetes are closely linked. And as we mentioned, increasing in prevalence worldwide. Both of these conditions are chronic conditions. They have multi-system impact, and there's an increased mortality as well as cardiovascular risk. We have people who live in deprived areas are often disproportionately affected. And we saw these associations quite clearly during the recent pandemic. Obesity is a key modifiable risk factor for the development of diabetes. 90% of adults with type 2 diabetes are classified as overweight or obese. So the mechanisms linking obesity and type 2 diabetes are complex. They're still being understood, but likely to involve a combination of adipose tissue releasing an excess of circulating fatty acids, hormones, cytokines, and this is thought to impair insulin signaling and increase insulin resistance. We also have chronically raised lipid levels, which can lead to impaired beta cell function and lower levels of insulin production. Next slide, please. So we've just seen all the figures on diabetes. The chart on the right talks about mortality in the context of obesity, and it's quite striking really, and perhaps not always appreciated, that life expectancy falls quite dramatically. So it's estimated that about 80% of people in the normal BMI range at the age of 35 will reach 70 years of age. However, this falls to approximately 70% for a BMI of 30 to 35, and it falls progressively. So it's only 50% for a BMI of 40 to 50. Next slide, please. So on top of the mortality, the physical impact, we have the human impact. When we put these two chronic diseases together, there is stigma that people with obesity often experience. There are the mental health associations. So both diabetes and obesity can impact on relationships, on working and social life, and psychological well-being. There's also often a need for monitoring, as you would have with any chronic disease, following a lot of guidelines, and all of this can have an impact on an individual, on their mental and emotional health. Next slide, please. Next slide. Thank you. So what can diabetes remission potentially offer? So we can potentially reduce the risk of developing complications from diabetes. We can improve blood glucose levels. There is a potential for deprescribing, so taking people off their established medicines safely, which reduces the medication burden, obviously, for that individual, for the health economy. We also have the opportunity to reduce healthcare costs and frequency of contact. And when we look at weight loss as with diabetes remission, we know that there are benefits from even modest weight loss, 5%. We have improvements in sleep apnea, metabolic parameters. And at the bottom is a quote from a patient from Diabetes UK who's achieved diabetes remission. And she says, "I feel at least 20 years younger. I have so much energy and I sleep like a log." So it is a fantastic thing for a person to experience. Next slide, please. Thank you. So what is diabetes remission? How do we define this? So we've recently had an international consensus on this, which is extremely helpful. It's defined as a HbA1c level of less than 48 millimoles per mole or 6.5%. That occurs spontaneously or following an intervention and persists for at least 3 months in the absence of usual glucose-lowering pharmacotherapy. Next slide, please. And a few other points around that. When we can't use HbA1c, when it's thought to be unreliable, we can use alternatives such as fasting glucose, plasma glucose, or estimated A1C. The thought is that we should test HbA1c just prior to an intervention and no sooner than 3 months after initiation of the intervention and withdrawal of any glucose-lowering therapies. It's advised that we test, that there is ongoing testing, at least on an annual basis, and also that we continue to test for complications following remission. Next slide, please. So there are various theories around this, but I'll just briefly talk to you about the twin cycle hypothesis, which you'll probably be aware of. So this postulates that type 2 diabetes is a result of excess liver fat, causing excess supply of fat to the pancreas. And essentially there is a dysfunction of both organs. And the idea is, if this is the case, that the condition can be returned to normal by calorie restriction. So if we look at the top of that diagram, any sort of excess carbohydrate goes through lipogenesis, promotes fat accumulation in the liver. If an individual has insulin resistance in the muscle, which can be determined by genetic or lifestyle factors, they will tend to accumulate fat more readily because of higher insulin levels. And then you get a resistance to insulin suppression from this increased liver fat. And over many years, what happens is you get increased basal insulin secretion rates. So this then speeds up the conversion of calories into liver fat. And you get it basically, essentially, there is a vicious cycle. And you can see how that impacts then onto the pancreas. We have the VLDL, which increases fat delivery to all tissues, including the islets. And this impairs insulin secretion in response to ingested food. And then you will develop postprandial hyperglycemia. So eventually, this triggers into diabetes. Next slide, please. So this is another way of looking at this. And when you look at remission on the right, we're looking at a reduction in liver fat, a reduction in pancreas fat, and potentially that improvement in beta cell function. Next slide, please. So how can we achieve this? The diagram on the left shows metabolic changes after initiation of a very low energy diet, which was about 700 kilocalories per day. And you can see that there have been changes in fasting plasma glucose, hepatic triglyceride content. And then the color-coded MRI scans on the right show the change in regional fat content before and after 8 weeks of an 800 kilocalorie diet. And interestingly, in this individual, they had not identified liver pathology beforehand, but just they were found to have very high liver fat content. So you can see there on the figure on the right there, post weight loss, how that liver fat content changed. Next slide, please. And the other important concept just to be aware of here is obviously this biphasic secretion of insulin. The first phase is obviously very important physiologically. It acts to suppress glucose output from the liver, suppresses lipolysis, promotes the uptake of glucose from the blood into the muscles. So when we're fasting, we have triglycerides released from the adipose tissue to serve as an energy source. And the fatty acids are oxidized and used for gluconeogenesis. So basically, the combined effects of these actions keep our blood glucose within range overnight. As soon as we eat a meal, we don't need those endogenous supplies. And if we don't shut them down, we end up with hyperglycemia. And that's what this first phase insulin response does after we eat. And it may be one of the first, or one of the first measurable defects in development of type 2 diabetes. And interestingly has been lost in people with pre-diabetes and even in relatives, first degree relatives of people with type 2 diabetes. So the study on the right looks actually, was really challenging this concept. The view we used to have that type 2 diabetes is invariably progressive and we have irreversible beta cell failure. And you can see there that fasting plasma glucose normalized. And this all occurred in the context of dietary energy restriction alone. Next slide, please. Thank you. So to talk then about the methods to potentially achieve remission, we have, broadly speaking, lifestyle intervention. We have the diet replacement, low-calorie diets, and other dietary strategies, and of course, bariatric surgery. Next slide, please. So how much weight loss is required? Consistently, we see that we need a substantial amount of weight loss, actually 15 kilograms, ideally as quickly and safely as possible following diagnosis. But it's important to know that, and for people to realize when they're being counseled on this, that not everybody will, of course, put their diabetes into remission. Next slide, please. So when we talk about lifestyle interventions, obviously the paper that we always talk about is the Look Ahead study. It yielded sort of years worth of data on the impact of a lifestyle intervention on health outcomes. And it was the largest and longest randomized trial looking at this and impact on weight as well. And so you can see it's an ongoing source of insight. Mean weight loss of 8.6% with that remission rate compared to the controls. Next slide, please. And I'm sure you're all very familiar with the DIRECT study, which was widely publicized and really did change practice. So a randomized controlled trial in primary care of a low-calorie diet, and there was structured follow-up compared to conventional management. Some interesting things around that acceptability, the use in primary care, the fact that 30%, I believe, actually participated. Average weight loss was about 14.5 kilograms. And there were 36%, I believe, that achieved remission for up to 2 years. So this was sustained. Next slide, please. And this is another study that's often mentioned in this context. Again, it was looking at the effectiveness and safety of a total diet replacement program for routine treatment of obesity in a primary care setting. And so compared with regular weight loss support from a practice nurse, this program of weekly behavioral support and total diet replacement, which was 810 kilocalories, seemed to be tolerable, led to substantially greater weight loss and greater improvements also in the risk of cardiometabolic disease. Next slide, please. And I'm aware there are a number of dietitians in the audience who will be the experts in this, but carbohydrate restriction has been well studied, and it is another approach we can look at. And of course, when we look at dietary strategies for anything, we're thinking about the individual, as we mentioned before, what is going to be tolerable, what is potentially sustainable for them. Next slide, please. And bariatric surgery really has got the strongest evidence base here. And just to highlight particularly the bar chart on the far right, looking at diabetes medications and how these proportions change. As you look at sort of procedures like gastric bypass, you can see that there's a greater proportion of people who aren't on medication following that. Again, fantastic outcome for these people. Next slide, please. And just following on from our comments around stratifying and personalizing, we know that there are a number of variables that impact on an individual's potential for diabetes remission. DIRM is a validated score that's been widely published, and you can put in a number of measures into that, and it can give you some feeling there as to what might happen. And next slide, thank you. So if we click through that, so it really, the challenges here. So we know that obesity is complex, and obviously it's great that a lot of reputable organizations are recognizing it as a disease. We start to have a lot more mature conversations about this, and we can go some way towards trying to destigmatize obesity. We have at the heart of it, obviously, the energy balance equation, but it's not as simple as that. We all exist within an environment that shapes us. We make our choices within a context. So we now have a vast body of evidence which shows that, like other chronic diseases, we have with obesity, it's a heterogeneous condition. So we've got a complex interaction of many factors that promote excess weight and impair our health. And once it's established, we have quite a number of factors that actually defend our bodies to some extent against weight loss. Next slide, please. So I just want to talk briefly on some of the behavior change models that are out there. There are many different theories and models on people's behavior change in chronic disease. This is one particular one, which I thought would be useful to highlight, would be how likely would that individual be to think they have that health issue? Is it well defined for them? How serious of a problem do they believe it is? So has that risk been communicated to them? Do they understand that? How well does that recommended change reduce the risk? What are the potential negative aspects of doing that particular behavior? And what makes you want to change? And I think the other important one is someone's self-efficacy. How much do they feel they can successfully make this change? Next slide, please. So what's not considered in the model? So obviously non-health related reasons like social acceptability, environmental factors we've just mentioned that can promote or inhibit a recommendation. It also assumes that everyone has an equal amounts of information. It doesn't consider socioeconomic status or education, and it doesn't really tell people how to do something, but it might be a useful construct. Next slide, please. So motivational interviewing is recommended as an evidence-based approach for behavior change. I think we find a lot of positive benefits when we start to incorporate it into practice, even in a light touch manner. So it's really a guiding style of communication, and it's designed to really empower people to change by drawing out their own meaning and importance and capacity for change. So it's important, it's based on all the principles we try to incorporate in consults, but it's really that idea of being a bit curious about people that facilitates the natural progress of change. So it's almost a process. So we are expressing empathy, we are helping the person to understand the discrepancy between where they are and where they want to be, and we're supporting their self-efficacy. Next slide, please. Thank you. So the spirit of MI. So really the key to this is we're getting the change from the person and we're not trying to impose it. So it's for them to articulate and resolve that. So the style is generally quiet. The counselling style is generally quiet. We're trying to elicit information. And readiness to change is not really a trait. It's not a fixed thing. It's a variable. It fluctuates. And so we're aiming for a therapeutic relationship that looks like a partnership. And we've shown how this can impact on behaviour change. Next slide, please. And so just some simple points. You'll all be aware of SMART goal setting. I think it looks deceptively simple, but I think it can be quite tricky to do. But when it's done well, it provides this feeling of accountability and boundaries. So this idea of making people be very specific about what they're going to do. Is it something they can realistically do before the next appointment? That sort of thing, rather than something that seems sort of insurmountable to them. Next slide, please. And then sort of really to draw to a close now, how do we set someone up for success considering all of this? So we've got two chronic diseases potentially when we're talking about remission. I think it's worthwhile considering how did that person, for example, with obesity, we think more around how rather than why. So rather than, a detailed look into how many slices of toast they had, it's sort of what are the real drivers and what are the real barriers. So we're looking at a comprehensive assessment, a tailored plan that considers a person's individual context. How sustainable is this intervention we're proposing for them? And how ready are they to take this on board? And how ready is our service also to support them? And last slide, please. So to conclude, we have now an international consensus for diabetes remission, which is extremely helpful and a very good foundation. We've really had, obviously, a paradigm shift in the way we are looking at this. And remission is now integrated into guidelines with clearly recognized benefits. There are a variety of strategies. There's no right way. But again, we want to think about what's right for that person. And we need to think about maintenance and sustainability. And you'll be well aware that there are now national pilot sites for diabetes remission, which is excellent news. Thank you very much.
Thanks very much. So waiting for a few people to put some kind of comments in the chat, but maybe we can start by just saying when people do go into remission, what should they be doing in terms of their reviews of their diabetes complications? And are you someone that when they go into remission that you stop the metformin, or do you continue the metformin? So a lot of people do continue metformin.
Mm-hmm. So we do. So I work in the bariatric unit as well, and our practice generally is to continue the metformin. In terms of what we do after someone has achieved remission, we talk to them obviously around maintenance of that and supporting them with the strategies and the tools. We do recommend ongoing screening for complications. I'm not sure if that's everybody's practice. That's what we would do. So continue retinal screening, foot screening, etc.
Yeah, I mean, we recommend that as well. Okay. And then in terms of that definition of remission, so I think that's something we're all struggling with, is that each community seems to be saying a different definition. What would you recommend as kind of easy definition of remission, or does it matter that we define remission?
It probably does. I think it is important, obviously, for research and practice that we have a consensus. And I think I'm just going back to my slides, because we have had a number of societies come together and suggest less than 48 for 3 months. Again, I don't know what people's views are on that, but I think that seems to be pretty reasonable to me, in the absence of any of the point there will be the absence of any pharmacotherapy. So as you mentioned earlier, the maintaining metformin, but I think we could probably still classify those people after surgery as having gone into remission.
Probably a touchy issue, but a very important issue, particularly with what's going on with personal finance, is that quite a lot of people find that they've done their health a good service, and then they go into remission, and then they're told that their free prescription is going to be lost. And obviously, most of these people are on lots of other medication. What do you think we should be doing about that? Because that seems to be a perverse way of encouraging people to do something for their health, that you slam them with a bill. Yeah,
I have to be honest, it's not something I've given a great deal of thought to, but it does seem like there will need to be some sort of national consensus on that, because that, as you say, that is quite significant for a lot of people, particularly when we consider that deprivation affects diabetes and obesity disproportionately. Yeah, it probably needs a wider discussion, I would have thought.
Okay, and then someone's asked, I think they're getting at the fact that, so they've said, do you think that definitions for remission should be different by ethnicity groups? And obviously, but I think you did mention that the cutoff for BMI for being able to have therapies, should that be different for different ethnicities? I think for the HbA1c they're getting at, there is some data to suggest that people of certain ethnicity have higher HbA1cs within the community who don't have diabetes. Mm-hmm. I don't know what your thoughts are on that.
Yeah, I mean, obviously we do tailor interventions based on ethnicity risk. So for bariatric surgery, for example, we would consider lower BMIs depending on ethnicity. So yeah, probably definitely it should be looked at for remission.
Okay, thanks. And is there a Prof. Taylor mentions about individual thresholds? So does that mean that the utility of BMI is something we should move away from?
I mean, I think it's difficult, isn't it? Because BMI is very easy to check, and you know, it's a very good measure for population level, and a gateway really for a number of our services. So I think in that way it's useful, but we know it's not obviously the most accurate way to measure risk. So we would look at more detailed, you know, sometimes we do body composition, or we will do obesity staging, for example, to stratify risk in more detailed ways. So it certainly isn't the whole picture, but I think it's difficult to leave it completely, would be my opinion. Yeah,
I always find centile lines are quite helpful. You're born on a centile line and you should stay on that centile line. So that's very helpful for discussing with patients about the fact that actually you should have been on the 5th centile, and although your BMI saying you're not too high up, you actually, you know, you have moved a number of centiles, and losing weight would really have a huge effect irrespective of what the BMI says. But yeah. Okay. Someone's asked, is the first 12 months crucial to aggressive lifestyle changes to achieve remission? So does what happens in those first 12 months determine the outcome?
I think there is some evidence to say that to put in some things like physical activity would certainly benefit. And I think we know this with weight maintenance, that we do, we often have great outcomes with certain interventions and motivated people, but we can have weight regain if we don't pay attention to those other elements. So I think it is important to have a maintenance strategy, yes.
Okay. And if you work with children, where obviously BMI is not a helpful thing, and can be hard to work out what target you should be doing for what is it weight loss you're using, or how are you defining?
I'm afraid I'm not a pediatrician, so I probably would have to defer to that one.
Yeah, because I think they're kind of asking I think the difficulty is there's not really very much data out there that suggests what it is. It was interesting that you said that you needed to push really hard. Our kind of evidence from a trial called Early Acted, where we intervene with people just after diagnosis, was that if in that first 4 months of diagnosis, if you get a 2 kilogram to 3 kilogram weight loss, you get 60% of them go into remission. So it does seem to be the longer you have diabetes, and I think we're seeing that even with bariatric surgery, that if you're out past 10, 12 years, it's very difficult to do it. So it does seem the closer you are to the diagnosis, the less weight loss you need to get your remission.
Yeah.
I guess it suggests that. Does the remission program accept patients who are taking antipsychotics?
So I'm not sure about that. I don't know if anyone in the audience can answer that. We have, I'm not sure whether the criteria for the national programs vary from region to region, but we have people within our service we can't refer if their HbA1c is above a certain level. I think it might be acute mental health crises. I'm not sure about the medication per se. I don't know if anyone else can answer that.
Yeah, it does vary by region. In our region, you can refer people who are on antipsychotics. But I think it does refer by region to region. I don't know, Philippa, can you answer, does your program take people who are on antipsychotics?
Apologies. Yes, it does. Now we find that obviously patients with serious mental illnesses, their weight does go up with their antipsychotic drugs. The only problem is that when a patient has a serious mental illness, often the concept of routine and joining a program is not very cohesive. So what is better is perhaps the digital option. They have one-to-one training with a digital provider. Then if they have someone that cares, they can help go through with them. So that's probably the better option. But yes, we certainly wouldn't rule anyone out on that basis.
Great, thanks so much. And in terms of monitoring post, so if someone goes into remission, what monitoring do you go back to? Do you go back to the standard yearly monitoring, or do you have more frequent monitoring?
Sorry, was that a question for me? I tend to go to yearly, or suggest that. I don't know what others would do, but.
Okay. Put in the chat if you think, if you do something different would be great. And then I suppose there's that thorny thing that one of the nurses said, if patients stay on metformin, does that mean by definition they haven't gone into remission?
Yeah, I don't really know what the answer to that is. I would have thought yes, it depends, but yeah, I'll be interested in what other people think.
Yeah, I mean, it was interesting. I was part of the remission workshop that was kind of set out. I mean, I find it, I try to encourage people not to talk about remission or cure of diabetes. Because if you think about diabetes, your risk of getting complication is dependent on you at some point having a glucose that has been above the normal level. And it doesn't matter what you do post that, you still are at risk of having complications. Mm-hmm. So in effect, what we're doing is we're saying that we're getting people to ideally controlled diabetes risk. Yeah. And I think I would have much preferred that term, because then we wouldn't have the problem of stopping medications because they now don't have diabetes, people getting the idea that they shouldn't need follow-up, but also having this discussion about whether you're on a drug and things, whether that, it puts you into remission. But yeah, it is a difficult discussion to have from that point of view. I mean, from the bariatric point of view, I mean, that it is interesting now that we're really pushing for remission, and NICE are kind of saying we should be focusing on people with type 2 diabetes. Do you have a service that you streamline people with type 2 diabetes, or do you feel that seems unfair that some of the other diseases are just as such as sleep apnea cause just as much cardiovascular risk, if not more, than diabetes? What do you do in your service?
So obviously, yeah, many patients could benefit, couldn't they, from being expedited. We do try to draw out the people with new onset or recent onset type 2 diabetes and flag them to our tier. So I work in a tier 3, which sits next to a tier 4. So we try to do that. But I mean, obviously, everything has changed with COVID in terms of waiting. So it's not been practically as easy to get these people through. But I would always try to flag them.
Okay. And then just one last question, and then maybe we just break slightly earlier. So one of our very bright dietitians has said, is the start of insulin resistance in the muscles due to the lipids causing phosphorylation of the insulin receptors, and that's the reason why you get the insulin resistance, as per Gerald Schumer's hypothesis of insulin resistance?
Fantastic. It sounds like she would be able to answer that question a lot more than I would. So.
Okay. Okay, so probably that's all the questions. Thanks very much for answering all those questions and things. So why don't we start with your group, Nikki? What kind of things were you?
So thank you to my group. So it was a really interesting conversation. And I think the vast majority of people had a level of experience with the Freestyle Libre. Some was a little bit more in depth than others. And I think one of the fascinating things was we had 2 people in our room that do paediatric diabetes, and they've used it in their cohorts with type 2, and all of us were like, wow, that'll be amazing, because you'll learn so much about lifestyle and how people can adapt and change. But what was really interesting that we learned from those people was that the children or paediatrics that had type 2, because they hadn't been doing finger prick testing before and they didn't have type 1 diabetes, this was a whole new thing, scanning, and actually they often didn't scan because they'd gone from doing nothing to suddenly having to scan, so actually scanning was burdensome. So whereas normally with type 1, going from finger prick testing to scanning becomes a lot easier, so it was the opposite direction. And actually there was a good point about stigma and type 2 diabetes. So some of these children didn't want to be wearing something that identified that they had type 2 diabetes as well. So I thought that was a really interesting point. And then we talked about instances where it was very helpful, so frailty, nursing homes. We talked about a recent publication in the Journal of Diabetes Nursing where it's been well used there, and how that can actually help community teams as well, that it can help with the demands on the team. But we also contrasted that with the numbers now that are going to be increased with the impending new NICE guidance, with access to all with type 1 and certain people with type 2. And we talked about the importance again of education of the person with diabetes, because it can't always be the healthcare professional that's looking at those results, making those adjustments on insulin, that there has to be that empowerment of the person that's living with diabetes. So I think that kind of summarises what we discussed.
Great, thank you very much for that. John, what did you kind of...
Yeah, so in answer to the questions that were asked, the initiation of the finger pricks from mainly the practice nurses in GPs was groups trying to achieve remission, highly motivated, escalating therapies, especially glucose-lowering therapies, people who drive for a living, people on steroids, and then there was also, not that it was prescribed, but from the reps, pots of strips for a month for newly diagnosed people, so they can try and see what different foods and exercise impacts their glucose levels, so they can make initial adjustments. Very little in terms of experience with FLASH. There was small pockets of funded by Abbott on poorly controlled with type 2, getting some good results in terms of HbA1cs, not through insulin dose changes, but through lifestyle adjustments based on the short-term feedback they get from the traces. There is also some limited pockets for people at high risk of hypos and requiring district nursing support. The question, should it be prescribed? The answer was yes, unanimously. And then if so, we got into quite a bit of good debate. A lot of it was focused on the people who are escalating therapies, i.e. on insulin, people who drive for a living, although there was a question about whether you can use, we know we can use FLASH for group 1 licenses, but we weren't sure about FLASH for group 2 licenses. People with learning disabilities, cancer patients and housebound patients. And then there was a lot of discussion around some of the practicalities. For example, if it was given out regularly, let's say tomorrow, things that are challenging is people who are on glucose lowering therapies. Do we need to be training patients on preventing hypos when the trace is showing that they're going down at a level of between 4 and 6? Learning new technologies for the patients and the practices, and also the ability to be able to link these systems to the GPs, data management system, so they can actually review patients from home. And then there's a final chat about continuation criteria. So obviously this is a costly thing compared to finger pricks. Therefore, at what point will we be discontinuing or stopping? And then there was some suggestion around 70% of usage, 4 to 6 scans per day, or do you have defined criteria when you initiate someone on about you're going on because we want to stop you moving on to something, or reduce insulin doses, or reduce hypos, or improve quality of life, so that if you do come to a stage where someone's not using their therapies effectively, you're able to have that reasoned discussion where you set criteria at the beginning or expectations.
Great, thanks very much. I think you pretty well covered everything. I don't know if other people have got things. Philippa, anything to add to the 2 people who've...
Oh, well, my group, they mainly used finger prick method But they said one of the issues that they have is that some people don't always use that method. They might bury their head in their sand if their readings are particularly high. They might not actually monitor themselves for a little while. So it very much depends on the patient on how well they actually use that. They have experience of flash for some type 1 diabetics, but the type 2 would be expectant mothers, maybe who are already diabetic, type 2 diabetic, who are not managing their glucose very well. So that would be a good example. A lot of them spoke about interpreting data, and a lot of apps out there. You know, you've got a limited amount of time when you're reviewing a patient, and you know they can have a deluge of data. So we talked about how it'd be good to have sort of like a dashboard summary, so that all the key headline data are clearly there. We talked about the importance of education and how apps can be used. So it's not just about your it's not about your glucose levels. It's also about, you know, supporting sort of the stress side of things and the family education side, and being able to link a meal that you've had. Our dietitian said that being able to keep a food diary using MyFitnessPal is a good one, because different foods affect different patients differently. So using the technology to actually see how a food affects that individual patient would be useful. And we also talked about insulin titration. So it's not only about reducing your insulin, but it's actually getting that optimized dose. It would help with that. And if you've got other complications, like we spoke in the presentations, you know, if you've got CKD, it's useful for controlling the co-complications.
Great, thanks very much. Hope, I don't know if you could just, as was always the case, if you sit at home, someone just come to my front door. So I don't know if you could just keep going while I answer, because he's not going to go away. Sorry about that.
Yeah, that's great. Thank you. Has everybody shared, or is Anjali?
Yeah, thank you. Yeah, so we had a really good discussion in our group. Fortunate to have an academic in the area within our group. So yeah, a lot of very similar points. What else did we talk about? So we talked about the groups in which finger prick testing is obviously beneficial in type 2 diabetes. We talked about the learning from the type 1 rollout, and certainly the fact that, as others have mentioned, the quantity of data, the fact that some people really like that data, what to do with it. Some people find it quite overwhelming. We talked about, again, when you have that volume of data, how you interpret it in a meaningful way within a consultation. So again, it's going to be clinician awareness and an education as well as patient education. We talked about who might benefit the most, and that we probably shouldn't be making assumptions on technology based on age. We know from the health, from the wider perspective, that there are some people who don't access technology, and there are different reasons for that. So we wondered whether this would disproportionately affect type 2. We thought about the benefits in terms of cohorts like people with learning disabilities, or even actually pre-diabetes. And Charlotte in our group talked about time in range and variability, and those insights that could be provided. So really good discussion.
Okay, that's brilliant. Does anyone else have anything further to add before we moved on? Brilliant. So we're now on to our next presentation, which is with Philippa, Lisa and Ryan. So Philippa, hello. If you'd like to share your screen, then I'll hand over to you.
So we talked about treating patients with type 2 diabetes. We've also talked about remissions. So it seems appropriate that we talk about prevention. And if you like, we're the prequel to this. So how we're going to do this is I'm going to set out the CCG picture and how the diabetes prevention programme has occurred in Lincolnshire. And then my colleague Ryan Morrow from our provider Xyler, he is going to go into a bit more detail of actually how the prevention programme works. And Lisa Masters is our senior engagement officer from Xyler, our provider. And what Lisa's going to talk about is our engagement with primary care. So I'm going to start off with talking about Lincolnshire's experience. So this is an interesting slide because this shows the prevalence in the East Midlands area of diabetes. Whilst this does include type 1 as well, we obviously know that that's going to be less than 5%. So there is a clear issue in Lincolnshire. So this is the Lincolnshire border here, and you can see these pockets of yellow along the east coast of very high prevalence. For those who don't know the area, this is Mablethorpe and the surrounding community, and this did have the honour, I suppose you like, of being the highest prevalence in England, of around 13%. Luckily, it has slipped down to the second place now, but obviously with such high prevalence, there's definitely work that we need to do. So we joined Wave 1 in 2016, and as I say, I think we were an ideal county because of our high prevalence. Initially, we did join with a couple of the CCGs in the Greater Lincolnshire area here, but we are now just one Lincolnshire contract. Silo also do the contract for the North Lincolnshire as well. So as I said, our provider has been since 2016 Xyla Health and Wellbeing, although we're in our third contract now. And we work very closely as a team. So I'm the project officer, but it's very much a collaboration. We liaise very closely and we work together. But there are other key relationships that we have. So the prevention programme is actually jointly funded by NHSE. It's funded by Diabetes UK and Public Health. So obviously Diabetes UK and Public Health are key players, but we also work with our local Better Births, our maternity voice partnership, and we also work with our local authorities. So what have we achieved since our conception in 2016 to date? So as you can see from these key stats, we've had over 15,000 patients referred onto the programme. And out of those number of referrals, we've had in excess of 8,000 who completed the initial assessment. So once a patient is referred, they then get contacted and an appointment is made. Now, it used to be face-to-face, and obviously it's been done remotely during COVID. But in that initial assessment, what we will look at is the key objectives and the goals that that person has, as well as we will take their BMI and their weight measurements and height and that sort of thing. And obviously we'll look at their HbA1c level to start with. So we've actually had over 400 groups. And as I say, those have been remote in COVID, and we're looking at going back to face-to-face at the beginning of April. We're phasing that face-to-face back in. And the number of percentage of participants that actually completed the programme is 60% plus. That may not seem particularly high, but it's worth bearing in mind that it is actually a 9-month programme. And some patients feel that even if they drop out after the IA, the initial assessment, they have enough information that they can actually go away and do it themselves. So that contact will have actually had some benefit to that particular patient. Some patients feel that they actually want more after the end of the programme, so we then signpost them after that. And we do find that a lot of our groups do stay in touch afterwards. They actually do like that peer support. So the challenges in Lincolnshire, we've already talked about the high prevalence, and what's worth noting about that is that even those official figures are probably 20 to 30% underrepresentation, because we know that the estimates of the undiagnosed are about 20 to 30%, so the picture is actually worse. But we have a lot of health inequalities that are obviously linked in with the high prevalence. This slide clearly shows that on our East Coast corridor as well, those areas with particular high deprivation do coincide with the high incidence of diabetes. So what we are keen to do is to make sure that we risk stratify our practices. So those practices who are in the higher areas of deprivation, who are low referrers, those are the ones that we are particularly targeting to make sure that their patients get an equal opportunity to be referred onto the programme. We talked a lot today about obesity, and obviously this is a very high risk factor for diabetes. Now, whilst we make it very clear that not all our patients who are pre-diabetic are overweight or obese by any means, we do know that if you are overweight, significantly overweight, you are 5 times more likely to develop type 2 diabetes. So unfortunately, 2/3 of our population in Lincolnshire are overweight or obese, and this slide shows the English average here. Now, these two areas, East Lindsey and Boston, won't surprise you that they're on our East Coast. Lincoln is the only one that is below the England average. Lincoln is our capital and has a much younger population. So moving on to another challenge is age demographic. So we have an interesting comparison of population pyramids here. On the left, we have the mid-year estimates for our first coastal PCN. So that includes the coastal communities of Mablethorpe and Skegness. The wiggly line out here is the Lincolnshire average. But what's really clear here is that we have a huge spike over the 65%. So we have approximately 32% of 65 and over patients in this age category, which is not a lot higher than the national average. So as we know, one of the things with age is that your pancreas gets less efficient, and then that increases the risk of type 2 diabetes. So it's worth us focusing in these areas where age is an issue. Lincoln, on the other hand, you can see the pyramid is the inverse of this, and in fact it has a spike at the 20 to 24 range because of the student population. However, as we've heard today, age is obviously decreasing, and we've heard people talking about children with type 2 diabetes, and we're definitely finding this is the case. One of our major issues we have in Lincolnshire, particularly in the Boston area, is the number of pregnant women who are either type 2 diabetics with pregnancies, or who are developing gestational diabetes. Now, 1 in 5 of our pregnancies are diabetic pregnancies. Then obviously that will include some type 1 diabetics, but that's obviously a very few number of that total. Also, that picture is likely to be greater in reality, because a lot of our patients will go out of county to give birth on the borders. Like Mablethorpe, they give birth in Scunthorpe, and in Boston they give birth in Peterborough. So we'll actually find that the 1 in 5 is less. So we're working very closely with our Better Birth team, Maternity Voice Partnership, to raise awareness of the risks of gestational diabetes and pregnancy, and the risk not only to the mother but the babies too, and how a lot of those babies can be very large babies, 10-pound babies, and also unfortunately the risk of stillbirth. So what are we doing to actually engage with the population? So before COVID, we had developed a workplace intervention programme, and we took this out to a variety of workplaces. the idea behind the programme was that we wanted it to be fun and interactive and engaging, because we actually found that that was the best way to learn. People were definitely more receptive if it was interactive. So we had a bit of team game playing, and we had lots of visual props, because again, people seem to respond well to props. So I don't know if you can see in that picture, but we had the fatbergs there. We passed them around and get people to guess how much they weighed. We also have these little blood bottle things that people could actually shape them up, and that was meant to represent people with glucose normal level in their blood, and how actually increased glucose levels make your blood thicker and more sticky, and that's how a lot of the complications occur, because your heart is obviously having to pump this sticky blood around. It's greater pressure on the heart, and also it doesn't get to the extremities as easily. So I think when people actually can see visual representations like that, they did respond well. And we went out to a variety of workplaces. We went to all the police stations in Lincolnshire, and what we chose to focus on there was stress, and how your hormone responses to stress can actually raise your glucose levels. We also talked about shift patterns, sleep patterns, grabbing food on the go patterns, and how that all impacts. And that was very relevant as well to talking to NHS staff, because NHS are one of our major employers in the county, as they are elsewhere. And we find that NHS staff don't always have the time to look after themselves. They're very busy looking after other people, but they don't actually stop and look at the stress that they're under, the shift patterns, and then the healthy lifestyle. Likewise, we've done a lot of engagement with heavy goods vehicle drivers who are sedentary, they're on the move, they're stopping at truck stops, etc. One of the other things we did, we went to Lincoln City Football Club back in 2019, and we got a lot of support from the football club, and they helped promote us, and we set up a stall and in half-term, pre and post-match. But I have to say, I've never come across so many type 2 diabetics in one place. So we wanted to target the male demographic there and raise awareness. But it was useful to have those conversations. Obviously, in the pandemic, we haven't had the same opportunities to talk to people face to face, but we tried to keep our profile raised with press releases, multimedia opportunities, and social media. And I think where COVID has really put the focus on diabetes is the fact that approximately a third of the deaths in COVID have also been diabetic patients. So we've sort of used this to help raise awareness. So what does our future look like? So we are going to continue to target our practices who are low referrers in most deprived areas. Tackling the health inequalities is something that as a CCG we are very committed to do. So we are looking at supporting those practices. However, it's not just those practices, we will take referrals from anywhere. So we're continuing to practice any support practices anywhere. And Lisa's going to speak about how she's been going into practices and the ways that she's been able to support and increase our referrals. We're going to focus on the East Coast corridor, and we're actually got a health inequalities project going on at the moment. It's funded by NHSE, and it's just looking at the barriers in the Mablethorpe and Sutton-on-Sea area to people engaging in the programme. And we're at the stage now where we're going to go out and talk to the people who have filled in the questionnaire and given us more feedback. And then we're looking at formulating suggestions of how we can improve their access, actually coming from the patients themselves. We're also going to focus on local group delivery as the face-to-face resumes. And what we're going to try and do is cluster those So one of the issues that we have is that Lincolnshire is a very remote area, and in the remote delivery, that was very useful to us because people didn't have to travel, and obviously the cost implications of traveling. So we're going to try and get the groups as close to the people as we possibly can. We're going to continue to focus on employers and also work with people like school children and young mothers with children. Coding and monitoring is always an issue that comes up, so we're going to review coding and monitoring within practices and the actual clinical systems. And finally, we're going to continue working on our partnerships. So, for example, we are working with public health at the moment, looking at the resumption of health checks and how they can link in with referrals, also looking at the role of hypertension and how that is related to diabetes. So my final slide will be looking at engaging with primary care, and these are the number of ways that both pre-pandemic and currently we've looked at actually our role in liaising with primary care. And we're glad to say that we're actually seeing that primary care is managing to ease its way out of being able to be proactively engaged with us again, which is great to see after the really difficult time that they've been through. What we'd like to focus now on is Lisa will talk through her role as the engagement officer and what she's been able to do linking in with primary care. So thank you very much, and I'll hand you over to Lisa.
Thanks, Philippa. I have tried to share my screen, my video as well, but I think our host has blocked that, so you might only just be able to hear me instead. Okay, so I've worked on the NHS Diabetes Prevention Programme, the NDPP, since it began in 2016 in Lincolnshire. I was formerly one of the health and wellbeing coaches, and I've had the privilege of delivering this wonderful programme in and around Lincolnshire for about 4.5 years. But now, as engagement officer for Lincolnshire, 80% of my role involves providing that crucial link between the NDPP and primary care. So this is in terms of upskilling and updating clinical staff about the programme content, but also working with staff to support and guide them how to initiate conversations with their patients, particularly when it's around the subject of weight reduction. With this in mind, though, the NDPP is not primarily a weight loss programme. It's a blood glucose reduction and sustainability programme of education. And as Philip has already mentioned, not all of our patients are overweight. So earlier this year, I undertook some clinical systems training and was granted my own smart card access. And this meant that I was able to contact practices directly and offer my support. It's a piece of work which has resulted in a huge response from practices, asking me to go in and assist with identifying their eligible patients by carrying out retrospective searches of their NDH patients. So then we've sent out eligible patient invite letters there and then in practice. And then I've been updating clinicians on the referral process updates, such as the continuation of the enhanced weight management incentive, which practices qualify for if, as well as having an elevated blood glucose in the pre-diabetes range, so 42 to 47 millimoles per litre, but also if their patient is a BMI of 30 and above, they qualify for this incentive. Also reverting to a 12-month HbA1c result as of the 1st of April. That's another important change. My colleague Ryan has already answered the question that I think Jane Townend asked. We are beginning a phased face-to-face return as of the 1st of April, returning fully face-to-face by the end of June. So the work that I've been doing during February and March has so far more than tripled the referrals in Lincolnshire. Getting back into practices has provided me also with a really invaluable insight into how differently individual practices are run. Just a couple of examples. I recently attended a clinical meeting of GPs and nurse practitioners in a practice who believed, all of them believed, they were making regular weekly referrals, when our record showed that they'd actually made zero, literally zero, month on month since April 2021. So clearly something was wrong, was going wrong. And after a lot of detective work, I've discovered that the email address the practice was sending these patient referrals to was a decommissioned email box. So these emails were then being pinged back into practice, into their generic email box, but no one was picking these up. The reason for giving you that as an example is that I think, ironically, I wouldn't have picked that up without having had this face-to-face interaction with this practice. So having run these retrospective searches, we would expect around 10% uptake by patients. I recently pulled 87 eligible patients after running one of these retrospective searches at another practice. And the operations manager at this practice made the decision that her and her team of 3 admin assistants would prioritise this piece of work. And they personally rang each of the patients during that coming week, just as a courtesy, so that the patients would know that they were expecting these invite letters. As a result, but proof of the power of the direct conversations we have with patients, this practice has had 62 patients out of the 87 invites take up the offer of referral. I'll hand back over to Ryan now, and thank you very much.
Hello everyone, can you hear me? So Lisa, you might have to confirm if you can hear me.
Yeah, I can hear you.
Excellent, thank you so much. Cheers, Lisa, and thank you, Philippa. Do you want mind going on to the next slide, please, Philippa? Excellent. Yeah, so I think as Philip has already introduced me, my name is Ryan Moran. I work for one of the providers called Xyla Health and Wellbeing, and I work closely with both Lisa and Philippa across the Lincolnshire contract. And today I'm just going to give you a bit of a brief overview of the diabetes prevention program run by Xyla Health and Wellbeing, and a specific element of the program too, and how we provide psychological support to our service users who are referred onto our service. For those of you that may not know, Xyla Health and Wellbeing, formerly known as ICS Health and Wellbeing, we run educational programs to reduce people's risk of becoming type 2 diabetic. I'm not going to go into too much detail in the program because we haven't enough time, unfortunately, but just to give you a very brief overview, the diabetes prevention program has 3 different elements to it, essentially. So we have our Eating Well sessions, which are around nutrition. We've got our Moving More sessions, which are around physical activity. And we also have our Taking Charge sessions, which are around the likes of behavioural change and how we try and encourage people to make healthy changes to improve habits and so on and so forth. And the topics that we've been to discuss in particular at this event today is how we provide psychological support to service users throughout the programme. And although we provide this psychological support all the way throughout the programme, there is a certain element of our service where we do give more so psychological support in comparison to other elements, and that is the taking charge element of the service. And that's going to be a bit of a focus, which I'm going to speak about for the next 5 minutes or so. There's one thing to address before I do start talking about how we provide psychological support to our service users throughout the programme, and that is that we do not provide counselling services to our patients, or service users as we like to call them, who are living with mental health issues. If this does arise, or if we come across a service user that is suffering from a mental health issue, we will signpost the service user onto the likes of a local IAP service, or maybe local organisations that can provide such support using signposting manuals that we at Xyla Health and Wellbeing have produced in order to try and signpost people accordingly onto the correct services. If you wouldn't mind going on to the next slide, please, Philippa. Thank you. I don't think it's loaded up just yet. And Jane, that's right. Yeah, the programme is over 9 months. If you'd like to know more about the service, we're more than happy to provide more detail after this session. Thank you ever so much. That's come up now. So when we was developing our content to support behavioural change and to give psychological support to our service users, our multidisciplinary team, which is a team of psychologists, dietitians, and physical activity specialists, they utilise the COMBI model of behavioural change. And when we think of the COMBI model of behavioural change, we consider all the different elements that help change or create new behaviours and the importance of these things that come together in order to make change to be successful. And the model has enabled us as a team, or our multidisciplinary team, to consider factors that maybe hinder capabilities, opportunities, and motivation in order for service user to take action. So we take into consideration these different educational components using the COMBI model in order to put the correct psychological support and behavioural change elements into the programme. And as stated by the NICE guidance for type 2 diabetes for prevention, the following behaviour change techniques should be included in a diabetes prevention programme, and that is information around provision, reinforcement of participant reasons for wanting to change, and making sure people understand what their values are and why they're making particular changes and aligning these with the values. We also look at goal setting, and we ask the service users to put action plans in place with graded tasks, which are again in line with their goals. And we also like them to put in, or we try and encourage people to put coping plans and also relapse prevention strategies in place to overcome such barriers. And all these elements are covered within our diabetes prevention programme. I'm going to give you just a bit of an understanding on how we tackle this throughout our service, and how we try and support the service users psychologically with making those behavioural changes. If you wouldn't mind going on to the next slide, please, Philippa. Excellent, thank you. There might be some animation to this, Philippa, so you might need to click it a few times, apologies. But yeah, we encourage our service users to set SMART goals which are aligned with their values, as I've just mentioned. So as opposed to just going through the motions as a service user, and just saying I'd like to, achieve this by the end of the diabetes prevention program, which is reducing my HbA1c or FPG readings, which are the blood readings which indicate whether or not you are pre-diabetic or type 2 diabetic or within the normal glycemia range. We ask the service users for them to think about what's really important to them. So it could potentially be that service user or the patients who are on the program is doing this because their family is really important to them and they want to try and improve their health or maintain their health in order to be able to provide for their family. So we get the service users to really think about what's important to them, and then we ask them to align that with their goals. So if, for instance, they wanted to increase their physical activity levels because they know that would reduce their risk of becoming type 2 diabetic, we'd set the goal around physical activity, but would also ask them to align that with what is the reason, what is the motivation around this? Why are you wanting to move more in general? And hopefully the response that we'd get from that service user who's aligning it with their family is, I want to do this because I want to be there for my family for a long time. Philip, if you keep pressing the forward button, I think the animations will start coming up, if that's okay. Thank you. Excellent. And just keep pressing away until that slide comes up. That's brilliant. So yeah, sorry, go back one more. Yeah, so we get them thinking about the goals they've already achieved as well throughout the program, and we put some focus on that for the service users, and we ask them to make group goals as well. So not just individual goals, but goals as a group, because then we see that as peer support, and people would get around each other and rally to kind of achieve that goal as a group. And we make sure it's the right time for them to move on to something else. So we like to put small steps in place that align with people's values, as opposed to giving them a huge task to do or a huge goal to make. We like to break it down along throughout the program. And we may then need to revise our goals depending on how we're going with achievement, and we may need to make them a bit more realistic or in line with SMART in order for them to achieve that goal, which is in line with their value. So values is something that's really important for us when we are working through the diabetes prevention program to ensure people are working towards their goals. If you wouldn't mind going on to the next slide, please, Philippa. And we also encourage service users to problem solve their own issues using information that they've learned throughout the program to help drive ownership and empowerment as well. So if the service user feels comfortable we ask them to problem solve in small groups. And again, this peer support and then sharing of best practice usually helps with coming around and solving the problems that people have with maybe making the changes along the way. And again, it provides that extra layer of psychological support when you have your peers around you supporting you. So we initially define the problem, what is the problem they'd like to deal with, and then we'll brainstorm the solutions, thinking of all possible solutions that can help people overcome such barriers. And then what we have them do is either individually or as a group, we'd have them pick solutions and then we'd have them implement that solution. And if it doesn't work, we completely appreciate that, and we learn to deal with relapse throughout the program, but review the results. And if it wasn't successful, then we'd work through the problem solving wheel again. But if it was successful, excellent, how can we build on that? So we like to problem solve throughout the NDPP, or the NHS Diabetes Prevention Programme, as we like to say. Moving on to the next slide, please, Philippa. And I'm pretty sure everybody is also aware that there is a lot of stress throughout the world, especially at this moment in time. There's a lot of stressful things that we have to deal with, and we know that if a person deals with chronic bouts of stress, or if they're having repetitive bouts of stress, we know that there is actually physical things that go on inside of the body which can put us at a risk of suffering from the likes of type 2 diabetes. So for some people, it's really important that we try to manage stress. So we do actually encourage people to build what we call their stress management toolbox in order to manage those stressful situations, to try and reduce the likes of the cortisol and adrenaline, which builds up in the body when you're very stressed, which then can put us at risk of becoming type 2 diabetic. So we talk about different ways in which people can cope with this. And here's just a few examples on the next slide that we talk about throughout stress management. And again, sorry, Philippa, it's one of those animated ones. So we often ask our service users to ensure that they're focusing on their breathing, which seems quite rudimentary, but often people don't focus on their breathing and they're not maybe there in the moment. They can go into autopilot, which links in with something that I'm going to talk about in the next slide as well. And point two is we encourage service users to talk about their concerns and worries that they have in the group, and it becomes a safe space. After several sessions, it becomes a safe space where people feel as though they can share their concerns and thoughts and feelings, which really does help out with managing that stress. And make time for your interests and things that you love. That's what we encourage as well throughout the program, because it's easy to forget about the things that you do enjoy doing and just do what you believe is very necessary, but actually things that you love to do is also super necessary. Take regular exercise, which we kind of talk about in our physical activity element of the program. And it's not just around exercise, it's also about how we can move more in general. And we talk about eating healthy and nutritiously throughout the program, and trying to change as well the thoughts that we have from being the likes of negative thoughts and problem solving those, and how we can make them become more positive thoughts, I suppose. And then we like to do some relaxation exercises throughout the program. And we also have some apps and recordings that we can signpost people onto to kind of manage those stresses. So we ask them to pick one or two of these points in addition to other things that we went through throughout the program to kind of add towards their stress management toolbox, as we like to call it. Next slide, please, Philippa. And then lastly, just around psychological support and behavioural change, there is one thing that we really do promote within the diabetes prevention program to help manage stress, and also just to help encourage behavioural changes, and that's mindfulness. So when we think about mindfulness, it doesn't mean a great deal to people until you start speaking about it, because often people are on autopilot and they're not too aware of the things that they may be doing, which could increase their risk of becoming type 2 diabetic or not leading the best of lifestyle. So people might become stressed, or they might just have certain coping mechanisms which are unhelpful habits, and they're not fully aware that they're doing these. But if we learn to become more mindful throughout the exercises that we roll out on the diabetes prevention program provided by Xyla, what we can actually start to become is aware of maybe the habits that are not helping us towards our goals and our values, and how we could possibly change these habits into a more positive behavior, which then in turn would help reduce our risk of becoming type 2 diabetic. So mindfulness is a certain element that we really like to work through on the diabetes prevention program. And again, I've just talked about one particular element today, and that's psychological support and behavioural change. But there is a lot more to the diabetes prevention programme run by Xyla Health and Wellbeing. So if you wanted to know more about our service, please do not hesitate to contact the likes of myself, Philippa, or Lisa. But thank you ever so much for attending our update on the diabetes prevention programme in Lincolnshire. If you have any questions for us, I'm not too sure whether or not we're doing them now. Hope, or if we're going to be doing them maybe at another point, but I'll leave that up to the organisers.
Thanks very much for that. Yeah, we're going to do the questions now, if that's okay.
Of course.
Doing things. I wonder if I could start with a question. I was trying to just sort of work out Lincolnshire and what I'd expect the pre-diabetes rates to be. And I kind of calculated that roughly 100,000 people in Lincolnshire will have pre-diabetes. So I was wondering, because obviously, I think you said you offered 15,000 and then there was a number that was 8,000 and then you've done 400 courses. I wasn't sure how many people attend a course, but it seems to be that if you refer, still quite a lot of people don't go onto the course. Is that right? So what happens to that? And my second question would be, obviously, if there's 100,000, are there plans to scale this up? Because it's going to take 7 years to get through all the people with pre-diabetes who currently have it. And by then, you'll have another 100,000.
Yeah, absolutely. Philippa, should I take this one, or would
Yes,
you
please.
like to take? Yes, of course. Yeah. So what we found, and it was a question actually asked by Jane earlier on, Robert, which was a really good question about completion rates on the programme, and if there's a difference between certain referral routes. And there's not necessarily a difference in completion rates, but what we found is if, say, for instance, people aren't well informed about the diabetes prevention programme prior to the actual referral being made into the service, it can result in a poor uptake onto the programme. So you can see that there's been 15,000 people plus since 2016 referred onto our service, and then 8,000 plus have taken up the service. And often people are refusing the service before their initial assessment, which is that first appointment, because they haven't been as well informed about the diabetes prevention programme. And maybe if that information was to improve, then we'd see the uptake onto the service hopefully be much better as well. With regards to our uptake onto initial assessment, it's actually above what NHS England expects with regards to conversion. So although, again, I think Philippa alluded to it, the stats may not look too favourable, it's actually quite good in comparison to what the profiles are expected of. And scaling it up wise, that is certainly something that we're doing at the moment in time with the likes of Philippa and our engagement officer. Lisa's on a bit of a roadshow around Lincolnshire at this moment in time to support practices with generating referrals into the service. And yes, we definitely like to step up and increase the referral onto the programme. Admittedly, there is a cap on the amount of interventions we're allowed to offer people on an annual basis, which we have to abide by, or we can look to submit an increase in provisions if NHS England allows so. But yeah, it's a gradual process, I suppose, with increasing that uptake and getting the buy-in from primary care to increase referrals. Philippa, I'm not too sure if you wanted to add anything onto that.
Well, I think you covered the main issues there, and as I mentioned in my presentation, we are actually looking at Mablethorpe to get the patients to actually say to us, what is it that stops you from, you might get the referral, but what actually are the barriers to you engaging? And a lot of the things they to talk about is time commitment, geographical commitment, things like that. So those things can be misconceptions. For example, we talk about it being a 9 months, but as Lisa said, if you break that down, it's actually only 25 hours over 9 months. So, it's how you impart that information that is really critical to motivating someone to sign up.
Yeah, thank you. And then the other thing you mentioned is you're trying to target. I wonder whether you have started thinking about targeting younger age people. And the reason why I say that is that although in the program, we kind of include everybody and things, the evidence is that if you're diagnosed after the age of 75 with diabetes, it makes no difference to your life expectancy. And if you're diagnosed at the age of 80, it shortens your life expectancy. So obviously people who are 70, who their 5-year ambition is to do it, I do wonder about us offering a program to prevent something that has no adverse outcome to their lives, and that should be perhaps focused somewhere else. But I'm not sure whether you've had discussions about that in your area and things, but it's just because of that volume that you're trying to take care of with your small places that you want to get the most for what you're targeting.
We've often discussed about an upper age limit, and the problem with that is there's no, for example, there's no two 80-year-olds that are necessarily the same, and there are definitely some patients that we would say it's not going to be suitable for. But you're right, we are definitely trying to focus on the younger cohort. We've been going into a lot of factories and trying to spread the word. The problem with the working age population, especially with the deprived areas, is that a lot of our patients are on 0 working hour contracts. So we are trying to adapt around them by offering evening groups, weekend groups, that sort of thing. The COVID pandemic did us a huge favour then, because it gave us remote delivery, gave us a huge number of groups for people to sign up to. So it's a little bit unfortunate that we may be losing that remote option, but we still had the digital option. So I think the combination of people's time commitments and also the fact that they may be more sort of tech savvy or maybe more used to using the technical option is that we can use the digital delivery. There was a cap on that of 20%, but luckily NHSC have removed that cap at the moment, so it doesn't actually mean that we can offer this to a greater number of patients. But again, it comes down to education, and we're trying to get the information out there. We're trying to get to, I think someone might have just put something up on the chat.
I was just going to mention gestational diabetes, if that's all right.
Yeah, absolutely, Lisa.
Yeah. We're actually, I completely agree, we should be targeting younger people, and that cohort of ladies who've experienced gestational diabetes. I'm spending quite a lot of time in practices to kind of drum that message in, because even if those ladies now have a normal blood glucose reading, again, they're eligible for this educational program. And the reason that's so important is because they're a younger cohort of people at that stage in our lives when we've just had, we've got young families. We're very, very susceptible to change because we want our children to have perhaps better habits than we had. We're very conscious of our own habits and some of our habits that we might not want to pass on to our children. And also that's going to have an impact on those families and how they grow up. And we know that ladies who've had gestational diabetes are 10 times more likely to go on to develop the condition later in life. So that's another area that we're trying to have a real impact on as well.
Yeah, I must admit, I kind of, be honest, I suppose from a research background, I really worry about that population. I think they need a different intervention than what we're offering to other things. I'm not sure if people have seen this week, there was in the Lancet, there was a huge, one of the biggest trials ever of trying to prevent people in Asia who'd had GDM. So this had 16,000 people in it, and they had no effect at all. Absolutely no effect. They didn't increase activity levels. They didn't have any effect on weight, and had no effect on people progressing to diabetes. So I do slightly worry that they're a different population than the other group, and in the diabetes prevention program, so the American Diabetes Prevention Program, people who had GDM had no reduction in their diabetes rates. So I think they're a group we need to work on, but I think we need to think about how we would deliver differently. That time of having had a baby, there's lots of other barriers, there's lots of other things going on, and it might well need a different program than
yeah. I think we'd be working closely with our Better Births team as well, Robert, to see how we can support people in addition just as the diabetes prevention program alone, because I think you're right in saying that service alone isn't going to be enough for that person. They might need support elsewhere. So we're looking to package that together with our Better Births team in Lincolnshire in order to provide the best services that would support them. But yeah, it'd be interesting. I mean, for Zala Health and Wellbeing, we've got some excellent outcomes of preventing people's risk of becoming type 2 diabetic. And we hope that we do see some of these effects take place within the GDM patients, although I appreciate they do need some additional support too. And I think that's where we've kind of had some success already with working with our Better Behavs team to ensure that they are being signposted onto other bits of support that can help them out throughout the programme. But yeah, I'm in agreement with you there, Robert.
Also, we did do a lot of work with schools. So we think that the key is to not only do you get the young people early, but they tend to go home and tell their families. So I did some work with a school in Boston, and just a little anecdotal story. This boy came in and said, oh, you know, I didn't have breakfast this morning, but I came in with, I drank an energy drink on the way to school. So my first thought was, oh, poor teacher, you know, you're going to have this massive high followed by a crash. So we then taught them how to look at the food label to actually work out how many spoonfuls, that's 13 spoonfuls of sugar in that one particular energy drink. We also had a mother who she had a newborn, and she had a toddler, and she was saying it was very hard juggling that. So what she would do is she'd be feeling tired. So to get a bit of an energy boost, she would have an energy drink. And then she found that she actually got to the stage when she was having 8 energy drinks a day, and not surprisingly, she was becoming pre-diabetic. But it was actually teaching her that that was the one issue that she needed to unlock. She hadn't made that connection. So a lot of it is about education in the young population.
Yeah, no, I tell you, I mean, in kids, we need them to have longer lunch hours so they eat slower, because there's very clear evidence that happens. But I mean, I have huge arguments with my school about my children is the snack thing. We don't need snacks between meals. There's no evidence. It's an invented thing that was invented by the food industry in 1972. There's no evidence your glucose falls between meals, and you don't need it. And to start that imposition that you have to send your child in with snacks for the morning and the afternoon, and that gets carried on into later life, that when you feel mid-morning that you know you need to have a snack, then that's just another additional calories that we're all carrying.
It becomes habitual then, doesn't it? It becomes like that's what you expect. Yes, but we've got one school, a primary school, Washington, that has had international attention in our district, and they've built food into the whole curriculum. So not only they're growing it, they have links with farmers. They have their own kitchen with proper knives, so they're taught how to prepare it. And I think that's the way to actually, you know, integrate food. Someone's just said, do energy drinks miss the sugar level? That's a really good question. I don't know. A lot of fizzy drinks, they're actually getting over the sugar level by reducing the amount of sugar and putting in aspartame or sugar substitutes. But we say they're not necessarily a good thing, because then the brain still sees it as a sugar rush. It doesn't necessarily distinguish between the glucose, although you are controlling your glucose level, so it's better than not. But we would actually get people to cut out fizzy drinks and sugary drinks, or at least reduce them.
Yeah, it depends what the drink is. If it falls under sports drink, then it misses the levy.
Does it?
That's always the problem. If it's yeah, so sports drinks avoid the levy.
That's very clever.
Annoying.
Yeah.
Yeah, that is a bit. Someone's asked about Lancet. Because I'm on this, I can't pull it up, but I'll put my email in, and if they email me, I'll send it to them. I'm very happy to send it to them. So thanks very much. That kind of brings us nicely to kind of the end of things. I kind of had to run off. I'm sorry, because someone had to ask me about a patient. It's always a thing if you sit in your office and someone always comes and asks you about someone. But I didn't really get a chance to say in our group what we discussed about just with the Libra, just kind of leave you with a thoughting thing was, we had a little discussion about whether there was evidence for Libra for interpretation and for changes. So a bit like what John was saying is that maybe you could use it to look at exercise, changing with exercise. We're doing a study at the moment where we've got people with Libras on and looking at changes in glucose with exercise. And as you'd expect, they don't change with exercise, because the thing that forces them down in people with type 1 diabetes is they've got higher insulin levels and things. So I think you have to be really careful in going back to the data and saying, what does an arrow mean in someone with type 2 diabetes that's falling? Because obviously they've got the normal hormonal system that would correct that, and it is normal for you to fall at a rate after meals. So I think we just probably need some further work done there. So thanks to everybody. I think it's been a really good morning. Lots of people have had a say and done things and things. So we'd like to just finish up by just to do one of those Slidos again. So will you alter your practice going forward is the first kind of question. And as in, will you change the medication you offer or focus more on lifestyle and weight loss is what we're kind of getting at. Do you feel that what you've learned from these experts who've talked to you today and what's on offer in Lincolnshire, which is, much better than we get in our areas, but, would that alter, if you did have those things? Great. So it's looking like people really feel that it's helped and it will change their practice, which is always what you hope for. I'm not sure if everyone has to do a reflection of a learning thing and then say how it would change their practice, but we have to do that for any course that we attend. But these are the kind of things you can put in your reflection. One, thank all of the speakers for giving their time. They give their time freely to do these sessions for you. I don't know whether Hope wants to finish us off and say.
Yeah, brilliant. Thank you so much, Rob. You've been brilliant today. It's been a fantastic morning. I know that I've certainly enjoyed it, and I hope that you have as well. And I'd also like to thank all of the speakers from this morning. You've all been fantastic, and hopefully they've shared a lot of useful information with you all as well.